So first I'd like to introduce Patrick Sullivan. He's a professor of epidemiology at Emory University's Rollins School of Public Health and co-director of the Prevention Sciences Core at Emory's Center for AIDS Research. Dr. Sullivan's research focuses on HIV among men who have sex with men, including behavioral research, interventions, and surveillance. Previously, Dr. Sullivan worked as the chief of the Behavioral and Clinical Surveillance Branch in the Division of HIV/AIDS Prevention at the Centers for Disease Control. He is the principal investigator of the NIH-funded studies to determine reasons for racial disparities in HIV among MSM, and to develop and test a couples HIV testing intervention for male couples, which I understand is being implemented here in Seattle, and to study combination HIV prevention packages in Africa, and to develop improved methods for internet-based HIV prevention. Patrick Sullivan.
And thank you for that introduction, and thanks very much for the opportunity to be here and participate not just in the presentations this morning, but in the discussions. So the topic that I was asked to address was case finding and treatment, and my first thought about case finding is that it feels to me like a word that we've used a lot for sort of STD, traditional STD case finding, and that it's always linked to this idea that we identify people living with an infection for the purpose of linking them to treatment quite directly. So my first sort of take on this was that maybe this talk should be about testing, but I think the implication of the title and what I'll try and do is say that it really has to be about more than that. It has to be about testing that leads to meaningful engagement and care. I want to just highlight one character from Greg's talk, which I think bears on this, which is that when we think about treatment as prevention for men who have sex with men, that the 052 trial actually included very few male couples, and that we have very little direct evidence about the magnitude of that reduction in infection that's likely to occur from treating positive men in male partnerships. However, there's no doubt that from a clinical point of view and based on biology and reasonable expectations that finding HIV-infected men, helping them link to the appropriate services, and doing the testing in a way that makes that connection is important. So I just want to start with sort of describing the problem. When we think about case finding, when we think about diagnosis, these are national NHBS data that have already been referred to in 21 cities. And overall in this study where 8,153 men were tested, about 1 in 5 were living with HIV. And 44% of those who were positive reported being negative right before they were tested for HIV. I think there are good reasons to believe that this is probably a somewhat over-reported extent of lack of awareness. These men are approached in bars and clubs. They didn't come in for a survey. They were approached for a survey. But nonetheless, there's a significant opportunity to reduce that amount of unaware HIV. In Seattle, by the way, these numbers are 15% prevalence and 15% unaware. So they look somewhat better than the national numbers. There are other ways of gauging our success with respect to diagnosing HIV in gay men and other MSM. One is an intertest interval, and although CDC guidance is a little ambiguous in a way and a little coy in a way, we think that something like an intertest interval of every 3 to 4 months may be important for men who are at high risk for HIV. It's telling that very few organizations are able to report the intertest interval, and so there's a bias here, but it happens that David Katz and Joanne Steckler and colleagues have recently reported this for Seattle-King County, where at the Harborview Clinic, the intertest interval among MSM was 215 days, and in Gay City, 257 days. And I'll say this is among these relatively rare places that can actually measure this metric. So we have a ways to go. Greg also mentioned the treatment cascade and the MSM-specific treatment cascade, where we think about 63% of men who are living with an HIV diagnosis have that infection diagnosed and have been linked to care to any extent. So we have to think about better ways to test and better ways to link to care. What would an optimized HIV testing program for MSM look like? One is that we need to increase the HIV testing frequency for some men, perhaps even to 3 or 4 times per year, by providing acceptable options, and I'll say more about that. 2 is that we need to be testing groups of men who are at high risk but who are currently not testing or not testing often enough. That may be younger men, that may be particularly men who are in main partnerships, and I'll say more about that. use new testing options to leverage networks. And this means perhaps dyadic networks in terms of partner testing, but also broader social networks. And using internet-based technologies to reach men who may live in rural areas or who may not want to use sort of gay-identified organizations. I'll talk a bit more about that. And one more thing I want to mention, but I won't talk about extensively, is building on the Affordable Care Act, expansion of health care coverage, and recent changes in the Preventive Services Task Force recommendations for testing and medical care to try to get other funders and other structures of care to help contribute to this more frequent testing. So we want to test men for HIV appropriately. We need to ask why those who don't test. And happily, although I have a half dozen slides on this going back as far as 1999 from the HIV testing surveys, which some folks in this room worked on, the answers to this question are always the same across the last 15 years and across cities. The reasons that men don't test is because they think they're at low risk for HIV infection, because they're afraid to find out that they are living with HIV, and then some smaller reasons like don't have time, don't know where to get tested, can't find transportation. And we'll talk about ways to address those. In terms of what's new in HIV testing, I'm going to mention couples counseling and testing. Also, in addition to at-home self-testing, we've been doing work with at-home specimen collection, where this is collecting dried blood spots and actually sending them into a lab. We're getting ready to launch an internet-administered kind of social network strategy for at-home testing, and also finding the role for at-home HIV self-testing. And again, Joanne Steckler, others in Seattle are important parts of this work. And in all of these, I think we need to be asking the question, how do we develop testing strategies that are integrated or are tied in with what the next steps are, which is linkage to care based on the testing approach. So I first want to talk about couples testing. Greg mentioned earlier that we did some work at CDC that suggested maybe as many as 2/3 of new infections among MSM were attributable to main partners. Steve Goudreau at the University of Washington and colleagues have done a really different modeling approach that suggests a somewhat lower percent, but I think we might agree that something between 40 and 60% of new infections probably come from main partners. In this context, we have recently adapted a couples testing intervention that was developed in Rwanda in the 1980s, is supported by the US government in PEPFAR countries, and has been demonstrated in observational trials to reduce new HIV transmissions in HIV discordant couples. And in this service, couples do all phases of the counseling and testing together. That means pre-test counseling, testing, getting results back, and post-test planning. I'm happy to say that as of March 30th of this year, the development of this has transitioned from Emory to CDC, and CDC is now in the process of developing TOT trainings, and this will be rolling out in the US under their leadership. And I have some preliminary data from a randomized clinical trial in Atlanta and from a 5-city scale-up, which includes data from Seattle. I also would just say that we have also colleagues from Cascade AIDS Project here who were one of our sort of early adopters, and we're really glad to have them as one of the current providers. Men are really interested in using this service. This is a paper from Bragg Wagner when he worked with our group at Emory. He's now a doctoral student at UW. Reporting that when you just describe the idea of testing with a partner and ask US MSM if this service were available, how likely they would be to test with a male partner in the next year, 4 out of 5 said that they would be definitely, which is about 50%, or probably would test with a main partner in the next year. This is the same across race groups, across age groups, and then although it won't show it, when we ask this same question in Thailand and the UK and Canada and South Africa, that it's between 80 and 90% everywhere we ask. Men would like to have this service. In our first study in Atlanta, we report data from 106 couples, which is 212 men, who came in as couples, both believing themselves to be HIV negative. And the seropositivity rate among all those men was 12%. In the community-based organization where we did this study, the individual testing clinic typically shows positivity rates of 5 or 6%. So men who come in as couples actually have a higher seropositivity rate. Why is this? Colleen Hoff in San Francisco talks about the mythical bubble of protection that you get from being in a relationship. And so we know from our own survey work that men who are in a main partnership perceive themselves to be at less risk for HIV and are less likely to have been tested for HIV in the past year. And then you sort of put that up against the observation that a substantial portion of new transmissions occur in main partnerships. The other important metric from this is actually couple serostatus. So this just shows in our initial 78 couples from a randomized clinical trial in Atlanta, and in the expanded evaluation that includes data from Atlanta, Chicago, Boston, San Diego, and Seattle, that overall something between 11 and 17% of couples are HIV discordant, where one partner is positive, the other is negative. In these couples, Rebecca Bagley et al. Estimated in a meta-analysis that within that partnership, 40% of those negative partners in those discordant partnerships will seroconvert during the duration of that partnership. So this is an important opportunity for intervention. In our qualitative work that led up to these studies, Rob Stevenson led this. These are data from Atlanta, Chicago, and Seattle. And I want to highlight a couple other qualitative findings. One is that men are already using HIV testing to inform their partners of their positive status. This is a guy who said, I knew that I was positive and I didn't know how to tell him. We hadn't had sex yet. We were just flirting around, but he was so damn persistent about being tested. And for whatever reason back then, I couldn't say it. So I said, let's just go get tested. And so couples counseling and testing is actually a great opportunity for guys, whether they've disclosed to their partner or not, to bring their partner in to learn his status. And the other observation is that the reason that guys, before this service was even developed, said they would want to do it is so that they could support their partner. This is a guy who was positive, and his partner tested positive as well, and he said, I think it would have been a lot better. During that time, all I wanted to do was hold someone's hand when he was diagnosed, and I knew it was emotional for him, and I knew it would have been a lot better if I had been able to be in the room and calm him down. So to wrap this up, I want to say our lessons have been that testing couples together may bring in men that have higher seropositivity rates than men tested alone. But couples testing offers a chance to now tap into that dyadic level of network to bring in the negative or perceived negative partners of men who know they have HIV. And the couples want to test together so that they can support one another. And our next step in Atlanta is to do a randomized trial where we're seeing whether men tested together actually have better rates of linkage, better rates of acceptance of antiretroviral therapy, better adherence, and better suppression because they now have a partner who's dedicated to supporting the positive partner in that endeavor. I want to talk a little bit about the older step cousin of home self-testing. We're all very excited to have an at-home self-HIV test, but for many years, there's been another product. This is a commercial product, which is a dried blood spot that men collect at home and mail into a laboratory. We know that some men, even back as early as 1998, 1999, were leery of rapid tests and leery of home specimen collection because they were worried about accuracy. And some men actually prefer to have their tests done in a lab. This allows confirmation of positive results, and it's acceptable. This is a paper from Akshay Sharma in our group who looked at data where we described at-home DBS testing and asked about men's willingness to use this kind of a service. Most of them said they would be willing to use this as part of an online HIV prevention campaign or study. When we asked those who were unwilling why they wouldn't want to use a kit like this, they said they're not sure it would be accurate. They don't want to give their mailing address. They want to talk to a counselor, or they thought someone might see the test kit arrive. So we took this information, and before we launched this programmatically, we actually developed that part of the page to highlight that the test was FDA approved and was 99.8% accurate. And we had an actual image of the box that would be shipped to their house in brown paper that didn't say HIV test, stamped on it. And so by addressing those two important concerns that men had, we launched another study. This was led by Christine Kozrapor, who's also now with you. It seems like all of our great people come out and work with you. And this was nearly 900 MSM who we recruited online. We never met them in person, and we mailed them an at-home specimen collection kit. They mailed us back a dried blood spot and received the results by an automated voice response system if it was negative, by a counselor if it was positive, and the linkage to care was provided either by Home Access or Emory. I just want to highlight an issue that came up in our Meet the Researcher discussion last night. The men in this study were, about 2/3 of them were under the age of 35, and about 1/3 of them were from rural areas as defined by census criteria for population density. Overall, when we mailed out these kits, 82% of them returned a technically acceptable dried blood spot specimen to the study laboratory. 18% did not, and return was more common among men who were white, younger, and more educated. Nearly exactly the same for men from rural and urban settings. 3.4% of those men had a positive HIV test result, and that's compared to an overall 3.6% seropositivity rate among MSM and CDC-supported counseling and testing settings. I think this is a really important observation. And about 40% of the men in this study had never been tested for HIV at the time that they signed up on the internet to be tested. 96% of the positive men got their result back through the phone system. That's a heck of a lot better than we used to have with testing when you had to come back for your results. And 80% of the HIV positive men where we got follow-up data were confirmed to have been linked to HIV care. The next steps in this is that CDC has supported Emory through APT and the MSM testing initiative to distribute 8,000 of these kits through the internet. We'll also have gift cards with scratch-off codes that will be distributed in venues where we go out to offer to test men and they say, I really don't want to leave the bar to be tested, but if they're interested, they can order an at-home kit. And then for those who submit a specimen, they're going to earn invitations. So if any of you are old enough, like me, to remember when Gmail launched, if you signed up, you got just a couple invitations that you could invite friends. We were very nice to people who said that they had gotten Gmail accounts because we wanted one of those invitations. And so for men who submit a specimen, they'll then have initially 3 referrals that they can pass on invitations to friends who might want at-home test kits. So this is really thinking about a social network strategy that we're taking into an internet space. Distribution is planned to start given the federal government approval deities next month, and this will be branded as the Know at Home campaign. So I want to wrap up by just emphasizing a couple messages. The testing needs of MSM are different than for other populations, and specifically, we need to be tested more often than we are at present. But the testing needs, like our other prevention needs, really change across our lives and change across communities. And so we're really starting to think about a menu-driven approach to testing that might support developing and implementing a plan of tailored testing. This means that if I need to get tested 3 times a year, I might want to have one of those tests with my partner. I want to have one when I go to my annual medical exam, and I might want to get an at-home test kit either for self-testing or to mail in. And so just starting to think about testing less monolithically and giving guys options that fit the configuration of their lives at that phase. And then finally, with respect to treatment, I think there's still unanswered questions about how we'll characterize the efficacy of treatment. But I think for the reasons that I said before, there are both prevention and clinical reasons to say that testing needs to be linked tightly to treatment. So in the case of couples counseling and testing, the opportunity is to enlist a negative partner in a discordant couple as the support person. NIH is supporting us to do a randomized trial of that question to see if that leads to better outcomes. But even when you're doing internet-based testing, we've found that through using very experienced linkage counselors, telephone, we're using Skype now to provide prevention counseling, that we can effectively link people to care in these ways. And some of the lessons learned from that are that when we send out these kits, we make very sure that we have good email and good cell phone contact information so that we can initiate a dialogue about linkage to care if we need to do that if there's a positive result. So I'm going to wrap up at this point. I always feel like I hate these slides because I always feel like I'm missing multiple people, but particularly colleagues at Emory, Christine Kosrapor, as I mentioned, who's here now, APT associates for the at-home testing, Christina Graby at CDC, and then we've been funded generously by NIH and by Emory CFAR, but also MAC AIDS Fund, I have to say, stepped in at a time when we had sort of done a randomized trial of couples testing and when CDC wasn't quite ready yet to move it out. And MAC AIDS Fund filled that bridge for us and supported the testing here in Seattle, supported training in Portland, and a lot of other activities. So they filled a critical hole, and I will stop at that point. Thanks.